All right. Okay, talk 5. Thanks for coming back. We're going to talk to you about a brief introduction to PROMs, patient-reported outcome measures, and how PROMs might or can improve healthcare. Okay, this is the background and context. This is a report from the King's Fund, which is a policy think tank in England. I don't know if you've heard about it, of the King's Fund. But essentially, 2010, they did a lengthy report called Getting the Most Out of PROMs, and they summed it up very well. Despite a century of developments in medical technology and vast improvements, the ability of medical science to prevent, diagnose, treat disease and ill health, attempts to measure the outputs of healthcare in terms of their impact on patients' health have not progressed beyond Florence Nightingale's time. So for only many, many years, the outcome we measured has been death. But while Florence Nightingale collected data on the dead, alive, our routine collection of outcome data has continued to be of similar focus, dead or alive, dead or alive. We haven't really progressed beyond it, this is what we're trying to say. The background. The context of outcomes is, well, we already looked at quality and effectiveness, and essentially what we're really interested in is what is the outcome of the patient. We have some reasons for healthcare. Essentially, we want to live longer. But not only do we want to live longer, we want to increase our number of years, but also increase our quality of life so that we're living longer and better. So I think the two together can help us summarize as two aspects of what we can see as better health outcome. And essentially, we want to know, essentially through the effectiveness of treatment, whether or not we are having better health outcomes, so longer life and better quality of life. But traditionally, our health services have focused on measuring one single outcome, mortality. And that is important. We know that, however, that helps us know whether or not we're surviving, we're living basically. But it's binary, isn't it? And it only gives us a part of a picture. And with medical advances in technology, lots of people are no longer dying. We are surviving, alive. Outcome 1, alive. So, but are we living better? Are we living longer? And how's the health, the quality of life of the survival? And increasingly, this is becoming more and more of an important and more of a focus now, because things are not fatal, comorbidities, but can cause considerable disability or reduce quality of life. Okay, so measuring health. I mentioned traditional ways of measuring. We like to measure mortality, very important. We need to continue to measure it. There's no way saying we don't need to measure mortality. Then also, we are very used to measuring impairment, recording symptoms and signs, recording mobility of the patient, how much pain they have. These are all what we learned from day one of medical school. There's mostly clinician reported loss, abnormality of physiological function, anatomical function. Every clinician is very well trained, and we're used to doing that. And in the health service, routinely, these are recorded in case notes and can be pulled up as a form of routine assessments quite easily. So yeah, these are usually clinically reported by nurses, doctors, the clinical team. Now there is an increasing focus to measure in terms of symptoms, functional status and disability. The WHO calls it now activity restriction. And also health-related quality of life or well-being, what they call activity participations, different terms, but essentially measuring the same things. And also satisfaction with outcomes. The last is patient experience, or some people call it PROMs. They're different from PROMs, okay? But essentially, increasingly, health status, health symptoms, disability, quality of life, health status and well-being is increasingly important to capture, are we living better, that question. And these have to be patient-reported. So either patient-reported outcomes, these the first two, or patient-reported experience should be the last one. So that's why these are necessary to be patient-reported and are essentially subjective measures. Okay, so how do we measure health data? 3 different ways of doing that. Clinician-reported, which I also mentioned, patient-reported, and also objective clinical measures. Okay, so there's often a cause of confusion in the field of measurements between objective and subjective measures. I just want to clarify it here that a lot of clinicians kind of feel that usually objective measures are seen to be more trusted and better than subjective measures, and that is incorrect. We know objective measures such as blood tests, X-rays, and observations from examinations, etc. And we know that that's objectively measured, but it's a statistical probability, varying. But a blood test can say, are you outside the normal range or in the outside when abnormal, inside normal? But there is a probability and a distribution. Okay, clinician and signs from clinical examination are objective with a degree of subjectivity. Okay, so when a doctor assesses how much pain the patient has, they're using their own subjective judgment. For example, the degree of knee movement, pain on abdominal examination. Okay, that's a degree of subjectivity. Then we've got things like quality of life, how the patient feels they can. And that, if we want to know that can only be subjective. Okay, so whether or not, so for example, if you want to look at dietary supplement, whether taking this tablet will increase your red blood cells, you can have an objective measure. All you need to do is give this patient tablet after tablet after tablet, and then take some blood and see if the red blood cells have increased. Then they know it's sufficient. This is if that's what you want to know. But if you want to know how taking this dietary supplement, this tablet, affects this person's symptoms, then you need to ask a subjective assessment. You can't just measure the red blood cells. You have to ask them, are you feeling less tired? How's your fatigue? Questions about the symptoms. And that is from the patient's perspective. So the objectivity and subjectivity doesn't mean one's more accurate or more trusted. They're both used for different things, and that's important to know. There's also a lot nowadays of validated instruments to be able, for us to ask subjective questions, which has good validity for objective states. So for example, an objective measure of how far someone can walk. You can do a neurological examination and watch someone walk a distance and walk back. You can watch someone climb a flight of stairs and come down a flight. So those will be objective measures and then record it. 100 meters, fine. But you can also ask someone, can you walk up a flight of stairs without much pain? Can you walk up and down the flight of stairs? And then they will tell you, and that would be patient reported. And that would be a subjective measure versus an objective measure, but they have very good and accurate validity. It's more difficult to get someone to go to someone's house and watch them walk up and down the stairs. Much easier to ask a subjective through a questionnaire. So that's why short functional status questionnaires are now validated and getting more relevant and much easier to do, and have excellent reliability and validity. So that's why subjective measures are now widely used. Just to give you a background on patient-reported questionnaires. Okay, so a little bit more background. In England, in the last 10-15 years, there's been a steady shift in how we should be measuring the quality of care. Essentially, nicely summed up by Lord Aradazi, which led the sort of a clinical review in the strategic quality of care back in the late 2000s. And so he said, if quality is to be at the heart of everything we do for the NHS, he's talking about, it must be understood from a perspective of patients. Patients pay regard to both clinical outcomes and the experience of the service. So he's saying we have to ask it from the perspective of the patients. And Donald Berwick also wrote, an American this time, that the ultimate measure by which to judge the quality of medical effort is whether it helps the patients as they see it. So increasingly, health services has a more focus to be patient-centered And we always hear people say, patient-centered care, patient-centered service, that's how to make our service more patient-centered. And they can mean lots of things, but essentially it's asking the patient's perspective of how they see it, through their experience of it, but also through their outcomes. And PROMs is talking about how they see their outcomes. Okay, so what are patient-reported outcome measures? So first of all, as I already mentioned, there are measurement tools, questionnaires, surveys, to harness information on patients' health about their own perspective on their outcomes, on their health status. Okay, so they're called outcomes, but actually we're not asking the patient, what is your outcome? Because it's hard for patients to quantitatively say their outcome. So we usually measure these in 2 points in time, and we ask patients about an aspect of the health status. So usually a baseline, and before, and one after. And then we're measuring a degree of change. It depends, this is condition and context dependent. So sometimes, your before and after is much more lengthy and gradual, so you might do repeated measures for long-term, for example, long-term diseases. I'll go on to events like sudden emergencies, what I am personally interested in researching, when you can't get a before event because they don't know they're going to have a stroke tomorrow, they don't know they're going to have a heart attack tomorrow. How do you capture real time before their baseline and afterwards? But in theory, essentially, you'd collect it in 2 points in time, 2 time points, and you measure the change. So you can mark them against patient progress or health interventions received. There's also lots of dedicated research, just to mention, and including colleagues here at Kyoto University on validating questionnaire types, concerted efforts by lots of dedicated research groups on developing questionnaires. Essentially, there are 2 types of questionnaires available, broadly termed as generic and condition-specific. Okay. So generic PROMs are, for example, the EQ5D, which many of us have heard of, perhaps used or seen. 5 dimensions, fairly easy, straightforward to fill in for patients. Lots of, and also SF36, again, very widely used, both. And they essentially allow comparisons between conditions. And they're called generic because they ask the aspects of a general health status. For example, they can be compared, they can compare across different conditions, and so fairly helpful for economic analysis because you can derive utility measures such as QALYs, etc. from it. In England, on the National PROMs program, it uses the EQ5D, and some of us use that quite often as well. And then there's also condition-specific PROMs, which are usually used alongside the generic PROMs because they have greater sensitivity and specificity to the conditions being used, to the relevant clinical details. The generic PROMs, one of the limitations and sometimes criticisms is that usually it's not sensitive enough or there's a ceiling effect, etc. But for condition-specific PROMs, much more helpful for the clinician because it's focused on measuring a particular aspect of health and much easier to understand the clinical management. And a common one and on the PROMs program uses for example, is an Oxford hip score for hip arthroplasty, Oxford hip knee score, and you might have used some of your own in your own research in specific disease areas. Okay, so what is our current state of our health services? These might be familiar to you. Care not is sufficiently patient-centered, perhaps. There's a lot of administrative and regulatory complexity, or continued dominance of acute hospitals. Just to name a few, variable productivity. Some are doing a lot, some are doing very little. Poor quality care, and dispirited staff. So, the health system is under a lot of pressure. Maybe many of us are familiar with aspects of it. So why do we want to measure PROMs? It's been advocated that PROMs may be useful, powerful tools for changing the health services. looking at different aspects of it from a different way, shifts the balance of power towards patients, as mentioned. It may be a disruptive technology. And we might know that it's new, and disruptive technology means that it might change certain status quo of the system. So that's been popular to do. At least in many countries are starting to increase the focus on it. And essentially, there are three ways that it may help and that it can help. First of all, it can help research. We know that PROMs are increasingly used for RCTs to identify and measure the impact of interventions. There's drug A trial on a trial better than drug B trial. And there's been a long history of using PROMs as an outcome measure for the effectiveness and cost effectiveness of many treatments and trials. Is this operation better than that operation? PROMs are used there. And also to evaluate the impact of policies. This is more challenging and more novel, but again, you can use that if there's a new policy, and does it change outcome? And you can longitudinally measure the impact on policies. Okay. It can improve the clinical management of patients. At the individual level, clinicians may use it to prompt and to support clinical care. And also, it's argued that it can improve the performance of services. So you can aggregate data and incorporate it into the process measures as outcome measures, looking at quality registers and clinical audits data. And increasingly, there's a desire to do this more routinely. So we know the use of PROMs in research to improve care. We talked about the widespread use of PROMs in RCT already, to look at interventions and policies. Is slightly more challenging. Now, England have had it's been more than 10 years in doing PROMs routinely in elective conditions like hip and knee operations, hernias and varicose veins in the past. And so we have some data from hip and knee replacements from PROMs and trying to evaluate policies. There are some challenges. We know that this is surgical rate in the bottom by how many hip knee operations, knee replacement operations is done. And this is mean preoperative Oxford knee score. So the higher, the better their knee function is, the lower, the worse. But we can see here that actually you would think that those that are doing more areas, hospitals that are doing more operations would actually, you'll probably expect there's actually no relationship in this figure, but you might expect actually that to be less severe because you're offering way more, but somehow there's no relationship between the two. It's very hard to explain why, unless you think, when we looked at need, demand, and use, some of us may be, maybe there's lots of unmet need. So actually, if you increase the rate of operations, there's still lots of need, so everyone is just as severely affected. But are there lots of people hiding, and there's a lot of unmet need of knee replacement? Really, it's hard to explain, but this is what the data showed. We also show that hospital volume has no impact on outcome. So the more hip replacement operations a hospital is doing doesn't really make them have better outcomes. Everyone's sort of clustered. So there's a bit of a flattish line, a little bit maybe, but it's not really interesting finding. Difficult to measure quality if everything is flat. Provider competition also has no impact on outcome. So the most competitive market and the least competitive market. So we talked about patient choice. Well, actually, it doesn't really change outcome that much for hip and knee. So there is another theory that PROMs can improve, another aspect is that PROMs can improve clinical management of patients. And really, there are 4 ways PROMs can do this. First of all, it can support and improve communication. It can prompt patients to reflect on their health, support dialogue, enabling the patient to tell their story, and gives patients permission to raise issues. It's often that, it's a very structured, so when, it validated tools, so it actually asks aspects, like a variety of aspects of particular function developed by, clinical and patient consensus usually. So if that question comes up, it might not usually come up in the consultation. And research has shown particularly some more sensitive kind of conditions, like on sexual behavior, sexual health, it might not, be immediately apparent to the clinician to ask that question, but if it's been completed by the patient or the clinician completes a PROM together, it might prompt patient to either raise it and say, oh, I saw this as a question, I'm actually affected by it, etc. And actually enables the patient to have a further dialogue. It supports greater focus on the patient's interests and and the idea that it should improve the appropriateness of care. And also maybe better detection of adverse problems and adverse outcomes. So sometimes it's used as a screening tool. It's included in the beginning of a consultation, so everybody does it. And when the clinician sees it in front of them and said, oh, well, this patient's got a post-operative score of much lower than what I'm expected. I'm going to ask them X, Y, Z. So it can actually detect adverse problems. Some clinicians use it to say, to help them differentiate whether or not patients should come back earlier or later for a review, for example. And hopefully also improve efficiency for the symptom system and the patient. So for example, monitoring long-term conditions, patients can actually log on and complete a PROM on repeated times to look at their own symptoms and also alert the clinicians to any changes in their symptoms. So one of the examples is Parkinson's.net in Denmark, and they have in the Netherlands, in a Dutch registry. And they have 50,000 patients registered in a national regional network. So essentially, very concerted effort into focusing on patients' concerns. So patients can actually report their PROMs outcomes, patient-reported outcomes, and is linked to their experience data and their clinical data. So clinicians can log on, patients can log on, and it's actually shown that it focuses the clinical care for these Parkinson's disease patients to their clinical concerns. It improved patient-reported outcomes. Basically, the quality of life and function has improved. It's helped prevent other side effects, hip fractures, etc., and also reduce costs. We have a successful network of using PROMs to manage clinical disease. The final bit is the use of PROMs to improve performance of services and the challenges to that. There's lots of support and encouragement for using aggregated data PROMs to compare different hospitals and practitioners and consider trends over time. And there is actually a belief that this will improve the quality of care. But the question is, how does it do that? Well, actually, PROMs is very new, and let's have let's think about why it may and how it can. And actually, there's a lot more need for us to research into how we can better use it and how we can use it to improve care. Policymakers, and we said there's a clinical willingness to want to measure, but the reasons for how it can do that, well, it's rarely made explicit, really. So there are really some theories that lie behind these beliefs. And these circumstances are context dependent and how PROMs data could improve care and what mechanisms it can to help improvement of care occur and what evidence we might ask to support these theories. Let's talk about these in turn. So first of all, the three underlying theories: supporting patient choice, improving accountability of providers, and enabling providers comparisons benchmarking is supposed to help improve quality. Okay. But we know that this is influenced by context. First of all, the degree to which the data is publicly disclosed. Sometimes PROMs data is kept very secret, hidden behind managers' paper files, behind administrative tasks. Oh, it's just another chart there. No one knows how to use it or interpret it. use of financial incentives, very similar to the question about clinical guidelines. Oh, well, it's there. How do people use it? Do people use it to change their clinical practice? Do people use it to improve care? Same kind of questions. How do we use financial incentives and sanction to support best practice? Perceived credibility of the data. Something like a disruptive technology, if PROMs is seen as a disruptive technology, is new. The familiarity with seeing it. Clinicians are not trained in the same way. You see a blood test, you know what to do with it. You see a PROMs data, Oxford HIP score, you might not know what to do with it unless you understand it. And if you see your hospital as an aggregated data on how the patient's PROMs were compared to another hospital, unless you really understand how it's collected, the use of it, and understand what it's for, that subjective measures are equally important and trustworthy, you might not see it as credible. And also the extent to which the data can help identify actions. And I think this is really important. A main point is sometimes it's not directly obvious for us when the relationship between outcome and what we can do to improve that outcome. Sometimes it is, but sometimes it's not. But unless, for example, inputs is, there's no soap and water, you can provide soap and water, and that would be an immediate change in practice. But with PROMs, it's actually, it gives you a smoke detector, a detector on how it works. It might be what aspects you might want to look at, but how you would actually get it to improve needs a deeper dive. It needs other clinical processes, and it needs a complementary data, and maybe a deeper dive to understand how to decide on actions for improvement. So there are 9 mechanisms by which care may improve. Let's look at these in turn. So we talked about supporting patient choice. We talked about improving accountability of providers by benchmarking, and then enabling provider comparisons. Okay. The theories behind each is interesting. So supporting patient choice, we think that patient will choose higher performing hospitals. So in the NHS, actually, there is a patient choice, so you can choose which hospital you go to. In practice, this happens a lot less than we think. It depends on the service, and it depends also on the availability of hospitals. But usually, but the theory behind it is that actually patients might choose a hospital with a better outcome, better PROM, for example. Threat of loss of market share and poor quality providers will then exit the market. And this is much more for a market model. And in the States, certainly this is used a lot more. Then there is improving accountability of providers. Threat of sanctions. We know that if your PROMs fall outside certain statistical boundaries, or if you consistently poor performers, you could have a sanction. You could have a regulator and sanction. You could be your service could be stopped, etc. And there could be the idea of how we can drive improvement with outcomes. And enabling provider comparisons. Essentially, this is where actually there's a lot more emphasis on now, is about professional ethos. Usually, there's a lot of pride for clinical practitioners to want their organizations to do well. If for districts as well, commissioners, public organizations, their reputation is important. And so if they know that their outcomes will be published, there's a drive to improve care. There's a belief that this will have focused the concerted effort to provide better care. And also the idea that you can have a peer-to-peer learning and peer-to-peer review, that those who are the best performers can help disseminate knowledge and best practice and influence the community in that way. So much more of a supportive, perhaps, aspect to it. So different reasons how, different combinations of how it might help improve care. There is little evidence for some of these. For example, patient choice, there's actually very little. I've already let you know that actually patients tend to choose, it's variable, but patients tend to choose their local hospitals, at least in England. they tend to just go to the closest one. I don't know about your country, that might be different. Well, improving the accountability for providers, and it's there's some evidence on this a little bit more, that for example, if it's publicly reported, so it's transparently reported. If the clinicians accept the metrics, again, this is very, if there's large clinical drive, there is more successful. What the financial incentives are, and if the national data is consistent with local data. So again, these are all context dependent. And the ability to identify actionable causes, and this is important because there's been research into the effects of effects of PROMs, and some clinicians are saying, well, actually, we know we're not doing well enough, but actually there's a lot of work to understand why we're not doing that well. And if there's a simple change needed, then it usually leads to faster improvement. And also there are some dangers in perverse gaming and things like that, as all data has when we collect and measure assessing quality. So when we enable provider comparisons, we find that when clinicians own the data and it's credible to them, it's much more helpful. And if the feedback is timely, it's been said that they can do much more with it. And the feedback provides advice on causes and remedies as extra bonus. So this is what the clinical community wants. So with the clinical data, if they own the data, they're able to use it more. And also the desire to be seen to be good by peers and the public as a stronger evidence of desire. But we did mention that when we looked at some of the data I shown you in England, at least, there isn't a huge amount to say overtly that actually this has improved care or it has measured differences in care. But a lot of it is maybe to do with the types of clinical intervention that PROMs is currently used. A lot of it is in elective care, where we know the outcomes are already very good. So mortality is very rare in hip and knee replacements, in elective care generally. And we know that actually through research and through many years of collecting it, that it's a very cost-effective treatment. And so probably partly to do with the reasons why there's little evidence on how effective it is based on what is being assessed. But there is so much of the health service that we still don't know about the quality. And where quality is much more variable. And actually, I would argue that focusing our measures on outcomes on these areas would be much more effective, much more beneficial for our health service. Areas of concern about quality, including unexpected emergency admissions. 40% of the NHS's acute hospital admissions, which have much, for the same operations, laparotomy, for example, major abdominal surgery, and elective have much lower mortality than the emergency equivalent. When you have emergency admission, you usually that space is not unable to be offered to elective care. So there's always a concern about capacity, emergency and elective balance. The management of long-term conditions, increasingly important. We don't know how this is this will be of increasing dialogue and importance, and there's much more unknowns about quality, multi-morbidity, dementia, very important. Primary care, social care, increasingly important, the transformation between health and social care and the integration of these two services. About quality of care homes, there's a lot of questions about that. And also mental health services. These are all really important areas where there is a lot more, at least in England, questions about unknown variation, unknown quality. So I'm going to show you briefly about two examples from our research from our school. The first one is my own, and the second one is my colleagues, about looking at PROMs and using PROMs in these aspects of care that we don't know much about, but there are challenges on how we collect PROMs in these areas. That's why it hasn't been widely done in the past. So unexpected emergency admissions, the challenge. This is my doctoral thesis. We don't have the information on the health status before the event. I already mentioned that PROMs you collect before and after, and you measure the change, and you can see the change in health status. But in emergency admissions, we don't know. We don't have that. So we can use, well, the question for me in my doctorate study is, what can we do? Can we use, for example, retrospective PROMs? So what's a retrospective PROM? Before the event, this is health status of a whole quality of life, whatever you want to use, and of the patient before the, and the time and the timeline. So this is the two axes. Before the event, the stylized diagram, patient's happy, plodding along with their normal daily life, and then they have an acute event, and their quality of life drops. And then they are admitted to hospital, and they receive treatment, and then they are asked a retrospective PROM to recall how they were before, and then a follow-up PROM afterwards. So retrospective PROM is like a recall PROM. You ask the patient during their inpatient how they were before the event. Because we are interested in capturing a baseline of patients, and we're about helping patients recover. So in my study, I've asked patients to recall how they were within a month. So they're still in hospital, and when they're after the emergency treatments, after they're well, before discharge, how are you before, when a month ago, before you were admitted to hospital with your current episode of illness, and you ask them to recall. And then a few months later, when they were recovering, we send them a follow-up PROM as per normal, how other PROMs, how the elective PROMs are done. So what is the accuracy, reliability of retrospective PROM? And in my study, so I first of all did a systematic review. It's published now. Looked at if there has been a prior comparisons between contemporary PROMs and emergency admission PROMs. And the comparisons are limited to elective admissions, of course, because we're asking to look at if patients have done a contemporary PROM and a retrospective PROM together, and how much agreement it has. So there are very few, but there are some studies, usually in hip and knee, arthroplasty, some prostate hypertrophy. Some studies, 6 studies, found very strong correlation and also very strong agreement, inter-class correlation coefficient of above 0.75. Okay, so we know that at group level from the literature review that PROMs can reliably predict contemporary PROMs, and the stronger it is for indices and shorter time levels is what the systematic review found, and also stronger for disease-specific than generic PROMs. Then I did my own cohort study in the NHS with patients of hip and knee replacement as well, a much larger study than some of the studies before. I also looked at people admitted routinely to NHS for hip and knee operation, who've completed a PROMs on the normal national PROMs program, and also completed a retrospective PROM just before their discharge, after their operation. And I found in my own study that actually the interclass correlation, absolute agreement, is 0.82 for disease-specific, and around 0.62 for EQ5D. So strong and very strong interclass correlation, absolute agreement, and the consistency is also good. And this is what my own findings were. So we found that retrospective PROMs can predict contemporary PROMs, and that we can use that as a way of collecting PROMs in emergency admissions. So I then done a feasibility pilot study in 2 emergency admission cohorts. First of all, with emergency laparotomy, 11 hospitals around the country, and with STEMI, ST elevation MI patients, heart attack patients, at 5 PCI centers, so primary angioplasty centers, 2 largest cohorts of patients, and did retrospective PROM and a 3-month follow-up PROM, and looked at the feasibility in terms of acceptability for patients and staff, and interpretability in how we can use it, for example. And you can see here on the right that the different hospitals have varying ability to capture PROMs, and this is normal. This is very similar to elective PROMs. Some hospitals have much higher recruitment, but on average, 85% were eligible of all the missions that survived were eligible. 84% of those were invited, and 72% participated for emergency laparotomy. This is large emergency abdominal surgery where surgeons have to open up the patient abdomen when they're admitted as an emergency and have varying diagnoses and pathologies. Quite an important, significant major surgery with about 10% to 15% mortality, 30-day mortality rate. It's improving, the mortality rate. Majority of patients survive, but can we do a PROM? ST elevation MI as a medical condition, patients have very short inpatient stays in this case. They have a significant heart attack, again, varying severity, but all of these are ST elevation, which puts them on a more severe category. They have to have a PCI within 90 minutes of, the guidelines is within 90 minutes in England at a PCI center. And after the PCI, before their discharge, they complete the PROM. Again, there's varying degrees of success in terms of collecting the PROM, but some very, very high, nearly 100% capture rate. So 85% similar percentage of patients were eligible to complete a PROM. There are those that have cognitive impairments, other impairments that prohibit social reasons that they couldn't do the PROM. 79% were invited and 92% participated on average. So yeah, this is just a little bit more information of this. At 3 months, I then collected their follow-up and as a feasibility study to look at response rate. So actually, there was 72% responded, and for emergency laparotomy as an example. And for the first time, we were actually able to look at how patients, so before I did the feasibility study, I had a look at clinical guidelines, anything about the recovery trajectory of the patients in emergency laparotomy, and I couldn't find anything on the internet. Actually, for the first time, we are able to quantify how patients' symptoms and health status recover after an emergency laparotomy episode. And we can see that actually for their JICLI index, so the overall score, patients actually recovered to baseline and improved. So the baseline was 93.3, and then their follow-up 3 months was 97.9. So it's not only does it suggest that they were before their acute event, there was some underlying pathology, and after 3 months after the operation, not only have they recovered, they actually improve. And then similarly with their symptoms. Their emotion and physical scores, the subscales, have recovered essentially, and the social score had decreased a bit. I mean, they have just undergone a major surgery. So actually these are quite helpful, and for the first time that we've done that. And for the EQ5D, we've also seen an improvement actually after 3 months after emergency laparotomy admissions, an average. So this is something what we can do that we've not ever done before, and we had 74% response rate, which is good. As good as the elective hip and knee actually. On average. So I'm going to talk very briefly about my colleagues' work in LSHTM as well. Another aspect of questions about quality of care is actually mental health and long-term conditions, and dementia care is an interesting one to study. People with dementia may have limited ability to respond to a PROM. So how can we capture a PROM for those with cognitive decline? Increasingly important question. As you know, my study, there were some patients that were not eligible. And for those, some were social reasons, like they didn't have an address and they didn't live in England, for example, but others were that they had cognitive impairment that was not reversible, so they couldn't complete their own PROM. So in that case, what do we do? And so actually my colleagues looked at patients and caregiver proxy PROM. So how can we do that basically? So they used the DEMQOL, which was developed by my colleagues in a London school. This is all published, so you can. I'm happy to provide you with references. So the DEMQOL-Proxy, which is a caregiver, so informal caregiver, so their spouse, like next of kin, to report the patient's quality of life. Some information about this, the domains that they cover. So really the question here is, can proxy scores predict patient scores? And they captured patients with different levels of cognitive impairment, patient with dementia, they self-report. This is the quality of life, and this is how the cognitive impairment. And we know that patients can report to a certain extent, but their quality of life goes worse when their cognitive impairment is worse. So this is the trend of the patient score, and this is the trend of the proxy report. So we know that caregivers consistently score below what the patient self-report is. But when the patient cannot no longer self-report because their dementia is so advanced, the caregiver can continue to report. And then they have done psychometric analysis to show that actually you can map across the two. So you can actually map across patients to caregivers. So when the patient can no longer report, you can use the caregiver's report. So they have looked at how you can do this. So just to conclude, some final thoughts. PROMs can help disrupt traditional PROMs. So hopefully, today we've covered the traditional ways we measure health and how that hasn't really progressed. The current complexities of a health service and the increasing need to focus and the desire to focus it back to the importance of our outcomes and our patients. And so hopefully PROMs have shown you that PROMs can disrupt as a disruptive technology, provide traditional approaches of clinical care, and that they can do this in an individual patient's level with the clinician-patient interaction, which we covered throughout the course, but also to policies, the importance in the policy climate. There are definitely lots of still methodological and practical challenges to how we can capture them and also facilitate the wider use, and also how do we improve healthcare services with them. But there is definitely potential and support in us helping to really look for the question on how do we define, assess, and measure quality, and how do we help support the integration of health and social care and all the many health challenges that our current health services face. So hopefully this is an introduction and overview to patient-reported outcomes. Thank you very much.